really important to go through. The position of the table. You want to have your table height about the height of your knee. And so it's always fun when you're at seminars and you're at club and you've got equipment you have to work with, you learn with it. But when you are in your practice, spend your money, invest your money on a set of equipment and get it proportioned right to your body. In the pelvic bench, you want to have that knee just level with the top of that table. And I really like the Richie Lou tables, and these are the Gonstead, right? Mm-hmm. Yeah, and they're good too, but Richie Lou makes, I guess we don't have any. I think they're just a little more solid. One of the reasons that the Gonstead seminars have a little wiggle is because Dr. Gonstead was adamant about having that stabilization, but having a little leeway for the mechanics of an adjustment. And they're both good tables. I just like Richie because they're just solid. They're, just a solidly built table. Anyway, that's the first important thing. 80% of your success on an adjustment on the pelvic bench has to do with what?
Set up in the legs.
Well, just look at the forest instead of trees right now. Just think broad term concepts.
Having a subluxation.
Patient relaxation, right? If the patient is not relaxed for an adjustment, you're going to fight yourself, you're going to fight the patient. You may hurt the patient, but more importantly, you're not going to probably fix it. So the relaxation is the most important thing. We can volunteer. Anybody want to come down? Okay. Let's just have you. So I always instruct the patient, have a seat right in the middle. And you lie down on your right side, just put your head right here, shoulder underneath you. And the things that you want to, the checklist that you want to go through, see, he already knows, right? We just bring that shoulder under just a little bit. You want to keep that arm just on the side of the ribs, just like that. You don't want to bring them back here, but just neutral, okay? This knee is brought up, just let that ankle just rest comfortably behind the knee. And I always let the patient know, and I even have to tell them, as we go, after a few adjustments sometimes, just let that foot relax. See, that takes that tension out of the back. But when you're getting your patient set up, let them know you're always in control. I mean in a positive way, okay? You got it. I always let the patient know, I've got you, you're not gonna fall. Because if the patient is starting to roll over, the first thing they're gonna do is they're gonna start to feel like I gotta fight it and keep myself from falling off the table. So I just bring the patient over. I'm gonna roll you towards me. See how I do this? I don't do this. Okay? Together. Roll the shoulder and the hip over and support the patient here. The lumbar spine, those discs, are so susceptible to twisting. And the lumbar rolls, that we learn, they can be damaging to those discs. Anybody grow up on a farm? Mm-hmm. Yeah. Remember okay, you had 2 ways to kill chicken. Okay, how could you do it?
I have a fun little story about it.
Yeah, just like that, or you cut the head off. Okay, why you can't bend it over and hurt them, but if you twist them, you can. And it's the same thing with these discs. The tensile nature of these discs. Once you start to twist like that, they're very susceptible to injury. So try to keep that patient neutral, just like that. Keep them just supported, just like this. Now we don't have enough time to talk about x-rays, but we x-ray every patient. Unless it's a child of 5 years or less and we're having trouble. If we have trouble figuring out where that subluxation is, we'll take a picture, usually a sectional. But we take films on everybody. Just very simply, Dr. Alex Cox said this, and I'll never forget it. If you take an x-ray for anything, take it so that you can count the number of vertebrae in the spine. I can tell you, are you okay like this? Mm-hmm. I can tell you, we've had so many patients that have come in that have been hurt by an adjustment. And I wouldn't call it an adjustment, I'd say it was a manipulation. And the first question I ask in the history is, did you have x-rays obtained? No, we didn't. So then we take a film. And say for instance, we run our scope and we find pressure at the L5, S1 level. Well, now we take a film, we find out what? It's a L6. Maybe it's an L6, transition 6. Maybe it's a spondylo or a spondylolysis. Maybe it's a base posterior. You know, not a true fifth lumbar subluxation. Maybe it's a medial fifth lumbar, and we can talk about how that has an influence with L4 right above it. There's a big difference between a sacral base posterior, the sacrum moving posterior, and L5 going like this. So laterally, instead of going back like this, L5 can go posterior and lift up in the back. That will cause L4. Okay, so it does like this, right? Versus the sacral base posterior, it can go like this. Now, if the sacral base goes posterior like that, L4 is always inferior on the lateral view. But if that's a sacral base, here's L5. L4 is always compensating by being inferior. Okay? But if you have a fifth lumbar that's gone medial, so it's come back like this, L4 always follows that pattern, so it flexes down with it. And this is a big deal, and I had, about 3 or 4 years ago, we had a case where we just couldn't figure out, the readings on L5. We took a flexion study, and we started fixing it as a base posterior, and it wasn't getting better, and we finally realized it's a medial fifth, even though it didn't present like that. Boy, once you hurt somebody, and you hope you get a chance to help them, to follow through. Dr. Troxel always used to say, if I could just have enough time with my patient, I know I could fix them if it's a chiropractic problem. And that's so true. And that all gets back again to trust. So an x-ray is so important so you can count. If you have a transition segment right here that feels like an L5 spinous, I will tell you, I will guarantee, oh, hey, doc. Oh, now we got to put the filters on.
Yeah, watch your language, dude.
It may feel like an L5 spinous process, and without a film to actually count that vertebrae, you're going to make them worse because that'll move that transition segment or the sacrum if it's got a pronounced spinous underneath L5, and that'll challenge that disc. And then the patient, well, they're not getting better. Well, we have to have a film. So that's why always have a film up so you can review it and look at it. So you want to make sure that fifth lumbar is identified. You want to look at that on the film, and then you want to find it on the patient so you know, without a doubt, that's L5. That's the one we want to move, first and foremost. Now, I've still got support right here. That patient doesn't feel like they're going to fall, so they're going to relax. Most of the time they're able to relax. That's important because we want to be able to find our contact point without causing that patient to get stressed and get all tight, because then you have to work against nature and you have to work against the patient. So identify where that L5 is, and let's just give this a listing as a PL. So that means it's L5 is going posterior, the spinous is migrated to the left side. The most important thing is we want to set it forward, right? So we get our contact point. And I always like to take my contact hand, my index finger, and just find L5 and just pull that tissue slack up. Then I can take my piezoform right underneath my finger, right here where I know that spinous is going to be, and we can contact it right there, just like that. Then I like to roll that patient just a little bit more, and I'll stabilize. We'll bring that shoulder up just like this. No, not this way. What is that doing to that disc, or those discs, right? We don't want to do that. We want to keep that shoulder neutral. And I like to bring the patient over just like that, and in my mind, I've got my elbow where I want that line of correction to be, right? And that's helpful when you have your film, and you look on that lateral film. If there's an increased curve, you may want to get that elbow down here, right? If it's not, it's going to make a difference on where that positioning is. Maybe it's straight out like this. So in my mind, I try each time where I want to lift that vertebrae, and I kind of let the patient know this is the way we're going to go, just like that. So I'll bring them over, and now a lot of times, especially in the Gonstead, we're taught, don't ever lose contact. Keep that hip and shoulder, the hip pinned down onto the table. I don't know if I totally agree with that. I think sometimes the patients fight you a little bit more. And then you get into trouble because after so many years you start going, oh, my shoulder and my back, you're fighting yourself a lot. So I think as much as you can keep that patient neutral and make that contact point right here I roll that patient over, I get my line of correction, I know where I want to go, I back away a little bit. Now that doesn't mean I let up. I still have the tension there. But then I like to lay my hip down in the back of that patient's leg and hip. I've got my chest centered right over my contact point, and then we'll just drop and set, just like that. It's not kicking that patient into the table, that knee. It's bringing that patient into the table so I can keep them stable while my hand, my arm, is doing the lifting, to set that vertebrae. And there's such a big difference with trying to force something versus setting a bone. And the first time, the first time you've got a patient that is acute, and they're in a, maybe even a disc herniation, and you set them up on the table, and you thrust, if you hurt them or make it worse, no matter how hard they try not to, subconsciously they're always going to